Hello friends. So I'll be giving a overview on this lactate myths. So I had this as a debate in Delhi MegaCon on 16th November. So the debate was that lactate is useless in ICU. So my opponent was another gentleman who would say lactate is very useful in ICU. So having said that, although I'll be doing this recording, so I'll be more focusing on certain nuances that one needs to keep in mind whilst interpreting lactate and why it cannot be looked at as the only biomarker representative of organ hypoperfusion and hypoxia. So I bring greetings from these two hospitals I represent, Manipal Hospital Yeshwanthpur and Manipal Hospital Yelahanka. So let's for the whole understanding of lactate, one quintessence is to have a conceptual understanding of the pathways that govern the lactate production. So basically, there are two pathways in the body. One is aerobic pathway, and then there is an anaerobic pathway. So what we really wish to have is this aerobic conditions where your pyruvate gets converted to acetyl-CoA in the presence of pyruvate dehydrogenase. So this is constantly happening in every cell. Pyruvate gets converted to acetyl-CoA, and this acetyl-CoA enters into the Krebs cycle. And here, in the presence of cofactors, so the Krebs cycles uses these cofactors, and they undergo oxidative phosphorylation and produces 36 ATP. So this is a sort of a pathway which is the energy repository in the any cell. So there is a constant energy production with 36 ATPs being produced through this aerobic sort of a cycle, repository of this energy. So when there is not much oxygen, so they undergo something called anaerobic metabolism. So this I'm sure you all would have studied. Just to recap, in the anaerobic conditions, in the presence of hypoxia or lack of oxygen, so what happens is there is a lack of pyruvate dehydrogenase. We'll talk about why there is a lack of pyruvate dehydrogenase that happens in sick patients. So instead of pyruvate dehydrogenase, there is lactic dehydrogenase. Pyruvate gets converted to lactic acid with the production of this NAD. So with the expense at the expense of NAD, and this lactic acid gets converted to lactate and hydrogenase. So this is our understanding as to why acidosis sets in, because lactates go up, and along with lactates there is a lot of hydrogen ions which contribute to the acid levels, and that leads to acidosis. And so lactic acid, even in this anaerobic pathway, this lactic acid undergoes glycolysis and they produce some ATPs, but not necessarily the required amount of ATPs that are needed, which is 36 ATPs, but there are some ATPs that are produced. So this is a typical sort of a simplistic sort of a overview on the cycles that happen in the cells and the production of lactate. So what happens when there is hypoxemia? This is just a schematic representation of a cell where there is a capillary supply of the cell. When there is a hypoxemia due to any reason, so our understanding is there is increased lactate in the cell. Because there is hypoxemia, there is decrease in the oxygen delivery, which leads to decrease in the oxygen consumption in the cell. And this leads to cellular dysfunction. So this is the sort of our simplistic understanding. When there is hypoxia, there is oxygen delivery comes down, oxygen consumption comes down, and cellular dysfunction tends to happen. So this is our physiological understanding of lactate. But what we need to understand as a myth is even aerobic glycolysis, which is the favorable pathway, when they get hyperactivated in conditions like sepsis, even in aerobic glycolysis, even in the absence of microcirculatory dysfunction, there is increase in the lactate. So this is something which all our intensive care trainees need to understand, that lactate is not only a byproduct of anaerobic metabolism. Even if your glycolytic pathway gets activated, even when there is no cellular hypoxemia, there is increase in the lactate. So this is what you need to understand. And any patient who comes to ICU who is on beta blockers, lactate may not necessarily go up even when there is microcirculatory dysfunction. So when they are on beta blockers, so there is lactate does not go up. So that is also a caveat that you need to understand. And there are different reasons for lactate to go up, because your liver dysfunction produces different type of lactates called the type B lactates, B type lactates. So which we'll talk about. So there are different conditions which causes. So it's not only cellular hypoxemia. So that is something one needs to bear in mind in ICU. When you see a high lactate, don't think it is only cellular hypoxia. There are various reasons that causes lactates to go up. So the myth is hyperlactatemia in shock is an undisputed sign of hypoperfusion, and tissue hypoxia should is a myth because it's not like all lactates are due to hypoxemia because they are shown in septic shock. Studies have shown that the PaO2 in the muscles are normal. And one needs to understand a lot of lactates are produced by the lungs actually. So many of the trainees would know here that a patient with asthma or COPD, mainly asthma, you would see a high lactate level. Not necessarily it means there is cellular hypoxemia because lungs are under stress and there is a lot of lactate production. I'm sure many of you who are listening to this would know asthma patients, when they have acute exacerbations, lactate goes up. And it is shown that lungs are can be the largest producer of lactate. And there are conditions where there is a proper mesenteric ischemia, and you would see that lactate not necessarily may have gone up. There can be minimal rise. We have seen this even in so, which means to say la high lactate is not equal to cellular hypoxemia as a rule. It can be one of the causes, but there are a lot of other causes as well. So, what are the other causes in sepsis which causes hyperlactatemia? There is mitochondrial dysfunction, which is one of the reason for lactate to go up, or there can be free fatty acid accumulation. And one important thing all trainees need to be aware is lactate is a biomarker, is a marker of lot of signaling pathways in the cell. Cells utilize lactate for a lot of signaling pathways, and there's something called lipotoxicity, where lipopolysaccharide causes reduction of this PPAR alpha signaling pathways. So, and there is beta oxidation of this that needs to happen. When there is a dysfunction of this beta oxidation of this pathway, lactates can be go up. So, what basically that tells is lactates is a fuel for a lot of cellular pathway signaling mechanisms. So, it is needed for good signaling mechanisms that happen in the cell. So, when there is hyperlactatemia, so we have understood in aerobic glycolysis, what happens? So, pyruvate, in the presence of pyruvate dehydrogenase, gets converted to acetyl-CoA. Why is it that this pathway does not happen? Because there is a deficiency of pyruvate. Why deficiency of pyruvate dehydrogenase happens? Because there has to be a flux of PDH. When there is an increased need for oxygen, there needs to be increase in the PDH levels, which we call it as PDH flux. And this flux of the PDH, which means there is a flushing of this PDH, which needs to fuel the cells. If that reduces, that gets reduced due to the cytokine storm, because the cytokine storm causes upregulation of PDH kinase, which reduces the flux of this PDH, which is needed for a good glycolytic pathway, which gets impaired in certain conditions, especially in sepsis. In sepsis, why does lactate? Not necessarily lactate going up in a sepsis is a reason for cellular hypoxemia. It is deficiency of PDH that happens because of the PDH flux that does not happen due to the cytokine upregulation causing PDH kinase, upregulation of PDH kinase, which reduces the flux. And why is this hypothesis correct? Because they have shown in studies by giving injection of dichloroacetate, which is an activator of PDH, they have found when you activate this PDH, it causes reduction of lactate, reduction of hyperlactatemia. So this hypothesis holds good. So you need PDH flux to cause good glycolytic pathway. If this PDH flux is impaired due to cytokine storm, which causes upregulation of PDH kinase, so that is when your lactate tends to go up. So this is our key understanding that I have sort of tried to explain as to why lactates go up in sepsis. And in aerobic glycolysis, rate of lactate production is dependent on the redox balance of the cell. So this is also important, and that has to be maintained well. When we say redox balance of the cells, it is maintained by this ratio of NADH and NAD. So this ratio tends to maintain this redox balance. And we already spoke about glycolytic flux that is needed for good aerobic metabolism, and that needs to be effective to cause sort of a good aerobic sort of a glycolysis and lactate decrease. So there are certain misconceptions about lactate. So we look lactate as a waste product of anaerobic metabolism. We saw that pyruvate does not get converted in the absence of PDH, LDH takes over produces lactate and lactic acid and hydrogen. In anaerobic metabolism, we consider lactic acid as a waste product which causes muscle fatigue and acidosis. This has been debunked. So the basic science studies have shown that lactate is an energy source for the cell, and there is a continuous utilization of lactate by the cell. And on the contrary, as I mentioned, so for the lactate production, hydrogen ions are utilized. So the hypothesis is because hydrogen ions are utilized for lactate production, so it should not cause acidosis because hydrogen ions are being utilized for the production of lactate. Because it utilizes hydrogen to produce lactate, so lactate causing acidosis is considered as a misconception. And lactate acts as a buffer. So because it acts as a buffer, so it's a misconception that it leads to acidosis. Rather, it should minimize the acidosis. So these are some of the misconceptions that we all have. So that's what we are trying to rectify as to how the PDH flux is important for this lactate, and lactate production itself utilizes hydrogen ion, which should reduce acidosis rather than contribute to acidosis. And lactate as a buffer should mitigate acidosis rather than cause acidosis, is something we have conceptually understood with the science of these lactates. So when you look at lactate in ICU, this I ask all my trainees, all of them failed to answer this. It's a non-specific. There are many causes of lactate rise. Lactate rise is not only hypoxemia. So we need to understand there are two types of lactic acidosis. There is L type and there is D type. So if any lactic acid you see, it is not only hypoxemia. L-lactic acidosis also, there are two types, type A and type B. Type A is what we see. If it is type A, it can be due to the hypoxemia or cellular hypoxemia. But there are a lot of causes in ICU where they commit type B lactic acidosis. And the common means post-seizure. Someone who's had a seizure, they would have a high lactate. That does not mean they have cellular hypoxemia. So seizure, thiamine deficiency, liver failure, or all malignancies. I'm sure most of the trainees who are listening to me would know any patient with cancer, with metastasis when they come to ICU, so they'll have high lactate. So these are all caused by type B lactic acidosis. And asthma patients, I said, they already lungs produce lactate. And if you use a lot of beta agonists, that also causes high lactate. And as I've already said, if they're on beta blockers, on the contrary, it does not cause lactate rise. It does not cause hyperlactatemia. So these are some of the causes. And someone who's on metformin, we know it can cause MALA, metformin associated lactic acid. So, which means you have to put in your mind and intellect to understand what is the type of lactate that may have gone up given the clinical context, not just lactate you see high and don't start giving fluids thinking it's cellular hypoxemia. There can be many other causes. And another limitation of looking at lactate as a biomarker is correlation versus causation. Increased lactate not necessarily always means it leads to worse outcomes because of the conditions I listed here. Post seizure, it doesn't mean they have a worse outcome. Thiamine deficiency doesn't mean they have a worse outcome. And liver dysfunction, they're all perennially having high lactate. So that is something we need to understand. We need to look at the cause. It is the cause which will determine which one has a worse outcome. It is just a marker. It's not a direct cause of poor outcome. And there is complexity in interpretation. So that is something we need to understand. And it should be context driven. So you have to take the clinical context to see why lactate has gone up. And hyperlactatemia, not all conditions are life threatening and not all critically ill patients have high lactate. So this is also a rule that you need to understand, that all critically ill patients do not have high lactate, and high lactate does not cause life threatening in all the patients. And there are alternative perspectives on lactate as to beneficial roles of lactate. As I said, lactate is needed for maintaining the redox balance of the cells by maintaining that ratio of NADH and NAD. Lactate is needed to maintain the redox balance in the cell. And lactate, as I mentioned, is an energy source. Look at it as an energy source for the cell and energy source for the tissue. Even during your stress or exercise, your lactate is needed for your muscle sort of a strength or muscle activity. So lactate is needed. So look at it as a beneficial effects. And this is very important for all my ICU friends. Lactate is a metabolic signal of immune function, of a T cell function. So it is as I said, it is the fuel for all the signaling pathways. So it is a metabolic signal of immune sort of a makeup of an individual, and lactates are needed for genetic expression within the body. So for all the cells to have a genetic expression, lactate is used as a fuel, and lactate is a biomarker of adaptive physiology. So just chasing a number, not looking into that's why in oncology patients, because there is so much of gene expressions that are happening, possibly we may see lactate being high, and it is an immune marker. So it is a fuel needed for immune expression. That's why maybe perhaps in oncology patients, lactates are high. So chasing just a number. So we don't go and chase and correct this lactate in oncology patients or in liver patients, because that could be counterproductive and biologically naive. And another caveat of high lactate is the measurement and interpretation. Because when you measure lactate from the arterial circulation vis-a-vis venous circulation and capillary, there can be differences that needs to be factored in when you're looking at sort of interpreting the lactate levels. And why we say lactate is not the only marker. If you look at the surviving sepsis guidelines 2021, lactate normalization is given a low quality of evidence. So don't go on chasing the lactate. You can look at it as one of the adjunctive marker, not as the only marker to look at normalizing. And even surviving sepsis puts it as a low level of evidence. And looking at lactate as a marker, as the only marker, is non-reliable and non-actionable. And what are the potential for harm and resource? Because if you only look at lactate and chase it, you may be giving unnecessary fluids, which may cause pulmonary edema, and there may be unnecessary ICU admissions. Because if you act upon lactate, most of the liver dysfunction patients will have high lactate, and that should not be the reason for you to take a decision to get them admitted to ICU. And this will deviate you from a good clinical acumen, and you wouldn't possibly look at other sort of indices of hypoperfusion, like capillary refill time, urine output, and you may fail to do other indices like ultrasound, focus, and echocardiogram to assess the volume status if you only act upon lactate, and even the cost and the time that may be involved. So what is the practical alternative approach? Lactate, look at it as one contextual data point and pay more attention and prioritize on your clinical acumen, capillary refill time, your ultrasound and echo indices to assess the hemodynamic status, and mixed venous saturation as a good markers along with lactate. Don't look at only lactate as a marker of hypoperfusion. If there is a high lactate, see whether there is a cell stress or a cell fatigue or a cellular hypoxemia, or is it a byproduct of other metabolic pathways, which I mentioned. It could be metformin associated, liver dysfunction associated, seizure induced, or lung induced, so on and so forth, or whether it's a metabolic sort of an indicator, which perhaps sometimes can be beneficial. So rather, I would suggest what one should look at is not only lactate, but look at all the other indices like heart rate, blood pressure, urine output, acidosis improvement. Of course, you look at lactate, hematocrit, end-tidal CO2 improvement, improvement in the mixed venous saturation, improvement in the sensorium, warm peripheries, reduction in burn, reduction in enzymes. And of course, when you're looking at all this, look into whether there is fluid overload status with low cardiac output like JVP, pedal edema, and crackles to determine what is the cause of the hypoperfusion that may be setting in, rather than looking at only lactate as a index. So these are some of the myths that govern the interpretation of lactate. So obviously this was a debate. So I just showed physiologically how we cannot only look at lactate, even from evidence standpoint. There's a low level of evidence to look at normalization. For all the trainees, the summary is remember 5 gospels when you see high lactate. I've just put it as 5 gospels. So the first gospel is be careful. So when there is high lactate, look at it as a red flag, pay attention to it, and look for other causes like liver dysfunction, cancer, whether seizure, low thiamine, beta agonist, metformin, or a lot of other drugs, chemotherapy drugs, immune therapy drugs, they all cause high lactate. Look at other causes. The second gospel is be respectful. Look whether there is a cell fatigue and whether it's an indicator of emerging critically ill, which may lead to increased morbidity and mortality. And be doubtful that not all high lactate is due to anaerobic pathway. It can be glycolytic pathway which may have got activated, and there is a pyruvate production and all that PDH flux that may have been affected by cytokine storm. And not necessarily when there is glycolytic pathway activation, it may not be life-threatening. It may be a helpful sort of a process to produce more energy for the cells. So that is something you need to, that is the second gospel. Third gospel is be mindful that lactate is an energy source for the cells, and cells need lactate for continuous utilization. And lactate is an important biomarker of multiple signaling pathways, and it's a biomarker of gene expression. It's a biomarker of immune sort of a makeup or immune reflection, or it's a immune cells. And it is important bioenergetic substrate, and it is important for multifunctioning signaling pathways. So this is something in it important. And these multifunctional signaling pathways may have anti-inflammatory effect, antioxidant effect, and immune modulation. So these are some of the beneficial effects of lactate. Be mindful. This is the third gospel. And the last gospel is be crafty, obtain health, interpret why lactate has gone up, and correlate whether it, and interpret why lactate has gone up, and correlate whether it is correlating to the disease severity. Not always it may have a direct correlation with disease severity. Not always it may have a direct correlation with the prognosis. So that's about it, friends. So I request you all to submit your valuable work to Journal of Acute Care. Of course, you can visit my website to read to this lecture. Thank you. Thank you, one and all. So don't wait to be rich to be happy. Happiness is free. Thank you.